Okay, so it should be open.
We'll give it a few more minutes for people to join, and then
for people to join in. If you have Nigerians coming, we like the Nigerian time. You know, you say something is at 5 and they come at 5:45. Just kidding.
Like I'll give it one more minute and then I'll do your intro. Okay, it's a little past the hour, so I'm going to go ahead and do your introduction. So it's my pleasure to introduce Dr. Shakirat Gold-Olufadi. She is a consult physician, dermatologist, and genitourinary medicine specialist at the University College Hospital in Ibadan, Oyo State, Nigeria. She is a fellow of the National Postgraduate College of Nigeria and a member of the Nigerian Association of Dermatologists, the International Society of Dermatology, and the European Academy of Clinical Allergology and Immunology. She had her residency training at Lagos University Teaching Hospital, and the diversity of patients seen in Lagos as the commercial hub of Nigeria exposed her to a wide range of dermatological conditions with expertise on how to manage these conditions. She's particularly passionate about health education and advocacy, and if you follow her on social media, you'll definitely see that. Her online dermatology teaching through her social media pages and her website, skinandall.com, has a wide reach to both healthcare professionals and the general public. So we're very happy to have you with us today, Dr. Gold, and we're looking forward to your talk on sexually transmitted infections, where we are, and the current management.
Thank you. Thank you, Jillian, for that lovely introduction. So today we are going to be talking about sexually transmitted infections, where we are, and current management. And I do not have any disclosures, neither do I have any conflicts of interest. I'll be going through this outline. I'll be going through this outline. Hold on one moment, please. I have some problem changing my slides. Excuse me, one moment. Just let me get this done.
That's fine.
I have, my slides are not just, okay, now we're good. Okay, so I'll be going through this outline, where we are and the impact of sexually transmitted infections, some common sexually transmitted infections and their clinical presentation, the diagnosis of the commonly encountered sexually transmitted infections. I'll talk on the management, including a note on syndromic approach to sexually transmitted infections management, the factors limiting STI management generally, and just talk about the way forward. So sexually transmitted infections actually remains a public health problem in most parts of the world. And they were earlier referred to as sexually transmitted diseases or venereal diseases. But the word disease actually signifies that the person is manifesting clinical symptoms. And we all know that sexually transmitted infections can occur. In fact, in most cases, especially in women, they are asymptomatic. So the word or the phrase sexually transmitted infections is more encompassing. So it's generally referred to as sexually transmitted infections now. And over 30 transmissible pathogens constitute sexually transmitted infections. And for the purpose of the discussion this afternoon, I'm going to be sticking to the ones that are acquired through sexual contact alone, where sexual contact is just the primary mode of transmission. So other infections such as HIV, hepatitis B infection, and there are some sexually associated infections that they are not just acquired through sexual intercourse alone, such as molluscum contagiosum, scabies. So I'm sticking just to the ones that are acquired through sexual contact. An infection may occur through different types of sexual contact. And extragenital contact is in fact an important route of transmission now. So where are we now regarding STIs? So the last World Health Organization data, more than 1 million new infections of sexually transmitted infections are acquired worldwide daily, 1 million. And an estimated 376 million new infections occur yearly with one of 4 STIs, either chlamydia, gonorrhea, trichomonas, and syphilis. In fact, chlamydial infection is the most frequently reported infectious disease in the United States, and the prevalence is highest in persons less than 24 years. More than 500 million people are estimated to have genital herpes simplex virus infection. More than 290 million women have HPV, that's human papilloma virus infection. And like I mentioned earlier, most infections may be asymptomatic. And if they're asymptomatic, increases the risk of transmission of the disease and increases the risk of complications such as infertility. Also, genital STIs, like herpes simplex virus infection, like syphilis, chlamydia, and gonorrhea, increases the risk of HIV acquisition. And in fact, they may account for up to 40% or more of HIV transmission. The Center for Disease Control estimates that 1 in 5 people have a sexually transmitted infection. And about 68 million infections in 2018 were diagnosed, with nearly 26 million new infections. Nearly $16 billion. If that money is added to the GDP of my country, I know where that will go. In medical costs for new STIs, and chlamydia, gonorrhea, and syphilis accounted for more than 1 billion. And in fact, 75% of these 2.2 billion of non-HIV related causes were amongst women. And this is just, anyway, I'm sorry about that. So I was trying to talk about where we are now concerning STIs. So please just intermittently, can you just let me know if you can hear me or not? Because I was just speaking, I didn't know you couldn't hear me anymore, please.
Of course, yes. We were saying we can edit this break out when Bill goes to post your recording to YouTube, so.
That's fine, thank you so much.
Yes.
So I was talking about that over 2.5 million cases of chlamydia, gonorrhea, and syphilis were diagnosed in the US in 2019. And about a 30% increase in this report occurred between 2015 and 2019. So occurred between 2015 and 2019. And for almost 20 years before this time, syphilis was almost eradicated completely in the United States, and even gonorrhea and rested on our oars. So there's an adage in Yoruba that says, "Agbotota dimeyin," that means the ram that moves back has gone to gather more power. So by the time syphilis, gonorrhea, and chlamydia, when they were coming back, they came back even more powerful than before. So cases of congenital syphilis almost quadrupled. And there's a notably higher burden in ethnic minority, in bisexual men, and in homosexual men. So, and in youth age between 15 to 24 years. So for the ethnic minority, for African American or Black people, they were 5 to 8 times more likely to have a sexually transmitted infection, nearly half of all 2019 primary and secondary syphilis cases, with gonorrhea being about 42 times that of heterosexual men in some areas. Young people aged between 15 to 24 years made up about 61% of chlamydia cases and 42% of gonorrhea cases. So a meta-analysis of studies of studies done in sub-Saharan Africa, in South African community-based study, Southern Eastern African community-based, and Eastern African amongst higher risk individuals. The prevalence was also higher amongst 15 to 24-year-olds than 25 to 49-year-old women for all sexually transmitted infections, except for herpes simplex virus type 2. So it's just showing that it's the active workforce, the 15, the adolescents, the young adults, that usually come down with most of these STIs. And in some areas of sub-Saharan Africa, syphilis still remains an issue. In Nigeria, the prevalence of syphilis has reduced greatly. In fact, a sentinel study that was organized by the Federal Ministry of Health, spearheaded by Professor Bakari, they did a testing for syphilis across the 6 geopolitical zones using the Treponema pallidum immobilization PPI recorded. So the prevalence of lead due to underpresentation and underreporting. Okay. Can you still hear me? I'm not sure if you can still make out what I'm saying.
Yes, we can, although it was slowing down and then speeding up again.
Okay.
But now it seems okay again.
It seems okay again. Thank you.
Thank you. Sorry.
So the prevalence of gonorrhea and chlamydia appears reduced in Nigeria too, but that is largely due to underrepresentation and underreporting. So it's common here in Nigeria. A lot of patients, most people don't even come to the hospital when they have symptoms. They would rather go to their local chemists, they'll go to the traditional herbal homes. And so by the time they are coming with symptoms, they are coming with complications. So maybe that's most likely why we're not seeing cases of syphilis anymore. Again, the impact of STI. Pregnant women affected with STIs may have adverse outcomes of stillbirth, neonatal death, and long-term sequelae, increased risk of cervical cancer amongst women. And to complicate matters further, especially in developing countries and low-income countries, lack of diagnostic facilities, inadequate treatment and poor access to treatment and late presentation increases the risk of complications. Among pregnant women, untreated early syphilis could lead to stillbirth in about 25% of cases, neonatal deaths in about 14% of cases, and hello?
There, now I can hear you again.
So men who have sex with men, transgender, bisexual are also groups of individuals that need to be considered specially because they have a higher rate of STI, HIV, and extragenital infection. In fact, from March 2013 to March 2016, there was a study that was conducted in Nigeria, and it was amongst men who have sex with men and transgender men. And the HIV prevalence, the overall HIV prevalence in Nigeria is about 1.4%, but the prevalence of HIV in them was 43.5%. And the study was done in the commercial capital of Nigeria, which is Lagos, and the capital of Nigeria, which is Abuja. The HIV prevalence in them was 43.5% and 65.6%. And they had a prevalence of, the chlamydia prevalence was 17.1% and 18.3% in Lagos. And overall, extragenital infection was present in about 20% of cases. So factors affecting STI, asymptomatic presentation, like I mentioned before, or asymptomatic infections, lag time to complications. So sometimes the time between the symptoms and the complications, if there are any symptoms, usually takes a long time. And even sometimes, there are some cancers that are associated with the presence of an STI, like hepatitis B virus, can cause liver cancer, HPV can cause cervical cancer, and all that. So the lag time to complications, especially makes people take STIs, it makes them take it lightly. Increased susceptibility of women and female adolescents. In a place like Nigeria, a woman is almost measured by her fertility. So when you don't have children, it's a big deal after marriage. Social factors like poverty, inadequate access to healthcare, substance use. There's something called chemsex now, where people are using, some chemicals to enhance sex, and that is also puts them at risk of sexually transmitted infections and at risk of, picking up partners randomly. Can you still hear me, Jillian?
We can't see your slides.
Okay.
Could you try?
Right. So, okay. So picking partners up randomly. Hold on one moment, please. Let me just, I'm trying to. So as I was saying, you can't see my slide, so I have to share the screen again, right?
Correct.
Okay. So. Okay, are you good now? Is this okay now?
No, I still can't see. Bill, can you just make sure she has screen?
No, I think, no, let me go back. I think I'm doing the wrong thing.
There it goes.
So can you see it now?
Yes.
Great. Okay, I apologize for all these itches, please. So sexual abuse and violence, sexually transmitted infections amongst vulnerable populations, sexuality and secrecy as a contributing factor. Sexuality is a part of normal human existence, but in some, even in industrialized countries, the developed world, some people still view talking about sexuality as talking about it in hush-hush terms or in hush-hush tones. And again, in Nigeria, I don't know whether you know this, but same-sex relationship is actually a crime. So the people that are, a lot of men that are actually supposed to be homosexuals choose to get married just because they want to save face and because they want to have children. And they have other partners outside the relationship and putting their partner at risk of some infections. So some of the risk factors for STI include a new sex partner, more than one sexual partner, a sex partner with concurrent partners, or a sex partner who has a sexually transmitted infection, inconsistent condom use among persons who are not in mutually monogamous relationships, previous or coexisting sexually transmitted infections, exchanging sex for money, for drugs, for favors. And again, when you're using some drugs to enhance your sexual practices and picking up random sexual partners, those are risk factors for sexually transmitted infections. Just a list of the common sexually transmitted infections. And the next table shows a clinical presentation of the common sexually transmitted infections. So gonorrhea, we have gonorrhea up there, causing urethritis, cervicitis, ascending infection like salpingitis, salpingo-epiritis, epididymitis, pelvic inflammatory disease, infertility through tubal blockage, and neonatal complications, like I mentioned earlier. So chlamydia trachomatis, similar to what I mentioned above, in addition can cause proctitis, pharyngitis, Rita syndrome, conjunctivitis, pneumonia, especially neonatal pneumonia. Syphilis is caused by Treponema pallidum, and you can have it in different stages: primary, secondary. In between the primary and secondary, we have the latent syphilis. Then we have tertiary syphilis. So there's early latent, late latent, depending on the time of presentation. Primary syphilis tends to just affect that's the site of inoculation of the organism, and it presents in form of what we call the chancre, and the chancre is usually a painless one. So most times it goes unnoticed. Secondary syphilis most of the time would involve the skin, the joints. You can have a papillosquamous eruption on the skin, the joints, while the tertiary clinical manifestation tends to involve the central nervous system and the neurological and the cardiovascular system. For early latent syphilis, that refers to syphilis from the time of acquisition to just 1 year after, and anything after that is late latent syphilis. And for latent syphilis, there are no clinical manifestations. However, there's serological evidence of the presence of syphilis. Trichomoniasis is caused by Trichomonas vaginalis, causes a frothy vaginal discharge, non-gonococcal urethritis, pelvic inflammatory disease, preterm births, stillbirths. Bacterial vaginosis occurs when the normal bacterial flora is replaced by some certain anaerobes and some fastidious organisms, such as Gardnerella vaginalis, Mobiluncos species, Prevotella, ureaplasma, and it causes a vaginal discharge, typically that has a fishy odor. Mycoplasma genitalium has now been recognized as a major cause of non-gonococcal urethritis. And in fact, amongst men that present with persistent urethritis, it may be responsible for as much as 30% of persistent urethritis and as much as 20 to 25% of non-chlamydial, non-gonococcal urethritis. The role in women is not so clear. It causes a vaginal discharge, but studies have compared it in both women that are pregnant and non-pregnant, and it's not really been shown to play a major role in causing a disease. So just showing you the discharge of gonococcal infection, usually a thick, whitish, creamy discharge, and that's a sign of urethritis. Gonococcal ophthalmicus, just to show that it can occur in both a child, and this is one of the patients from our clinic, and in an adult. Different slides showing vaginal discharge. The next set of infections, chancroid, LGV, granuloma inguinale, they are not so commonly seen, even in sub-Saharan Africa, where they used to be common before. So I won't really dwell on those ones. So, but just to know that chancroid causes painful genital ulcers with buboes, may have buboes. LGV is caused by the serovas L1 to L3 of Chlamydia trachomatis, and it causes buboes and a genital ulcer disease. The buboes are usually painful inguinal swelling, usually unilateral, but they may be bilateral and they may suppurate. So going to herpes simplex virus infection, almost about 85% of cases of HSV is caused by HSV, herpes simplex virus type 2, and it causes a painful genital ulcer. And it can also cause neonatal infections, especially for someone that has the infection in the 3rd trimester. Genital wart is caused by different species. Almost 100 species of HPV can infect humans. But the most common species that cause infection, there are about 30 of them. And of these, the most important ones are the ones that cause genital warts and the ones that cause genital cervical cancer, vulvar cancer, penile cancer. So type 6 and type 11, they are the ones commonly associated with warts, genital warts, while type 16, 18, 31, 33, 35, they are the ones associated with cervical cancer. So this is one of our patients, had epitic Whitlow, is HIV positive, had epitic Whitlow, had herpes simplex virus, oral herpes simplex, and also had herpes genitalia. So this is LGV, and this is showing some of the patients in the clinic. And like I mentioned before, in Nigeria, using UCH as an example, so I just took some data before coming for this presentation. In 2019, we had about 144 cases of sexually transmitted infection in the clinic. And more than half of these cases were genital warts. Just to further, and about 20% of them were gonococcal infections. The rest were distributed between vaginal discharge, scabies. So scabies is still very important in our environment. So we've realized that a lot of patients, they don't even, when it comes to urethral discharge, cervix, they don't come to the clinic. And it's not that these things are not happening out there, but the ones that are most worrisome to them is the one that a partner would likely notice. So genital warts, they are more likely throughout discharge. In fact, some of this particular patient, this is a patient of in UCH in Nigeria, managing STI is between the clinical microbiologist and the dermatovenerologist. So this patient was from the clinical microbiologist, and this patient was actually still having sexual relations despite the fact that she had this kind of warts. So she was not even asymptomatic. So these are some of the other infections, but I'm not going to talk on these ones. I wanted to show a slide of scabies because it's still very important in our own environment. a lot of patients present with scabies as a sexually transmitted infection. All right, can you still hear me? Jillian, am I good?
Yes, you're good.
All right, thank you. So moving on to diagnosis. The diagnostic test can be grouped into direct visualization of the microorganisms using microscopy, can be a direct microscopy or a smear stained microscopy, culture, serological testing, and the newest of this test, the nucleic acid detection, using amplified or non-amplified nucleic acid detection tests. And what's the purpose of diagnosis? For surveillance and screening, for purpose of diagnostic tests, you want to, it's not just because you want to diagnose asymptomatic patients. It's not just because you want to diagnose symptomatic patients. You want to make sure that at the level of asymptomatic patients, you are picking up those patients even when they're asymptomatic, to confirm syndromic diagnosis, for etiologic diagnosis, for antimicrobial susceptibility testing. So it's important that the laboratories doing this test, you have good quality assessment, quality control, and validation is necessary to ensure reliable tests. So I'm starting from way down there because we're talking about current management. So we're talking about current management. So there are several nucleic acid amplification tests now that are approved for the diagnosis of a lot of these sexually transmitted infections, especially gonorrhea, chlamydia, and trichomoniasis that are FDA approved. So what happens with nucleic acid amplification is that you collect whatever sample you need to collect, be it a vaginal discharge sample through the special swabs that you're going to collect the sample with, be it urethral discharge. And so for males, most of the time, you are using urethral swab samples or a first pass urine. For females, either it's endocervical swab sample or you're using a high vaginal swab sample. For females, it's not encouraged to use the first pass urine sample. So after the samples have been collected, the nucleic acid of that particular organism that you're trying to test for is extracted. So then what happens is that you obtain a primer that is complementary to the target nucleic acid sequence. And so the sample goes through an amplification phase. And that amplification phase occurs in something we call a thermocycler. So the amplification phase is, is divided into 3 stages. You have the denaturation phase that takes place at 95 degrees. The annealing, okay, so the DNA strand. So if it's an RNA sample, for example, is first changed to, the complementary DNA is first gotten. And so the annealing is done. And this takes place at 72 degrees, where you separate the DNA itself. Then extension phase, which occurs at 56. Degrees, most of the time at 56, between 55 to 59 degrees. Can you still hear me?
Now we can. There was a pause, but it caught up.
Yeah. So these cycles are then repeated several times. So that's the amplification, depending on the DNA product size. So identification of the target DNA products can be done real time. So when you see it as real time, PCR, then you amplification. If it is a conventional piece, form something we call the agarose gel electrophoresis, and the bands on the agarose gel will now be visualized with an ultraviolet illuminator. So all the nucleic acid testing, they use this principle, the laboratory nucleic acid testing. So there are some nucleic acid testing now that are now point of care tests that can test for chlamydia and gonorrhea. In fact, the study that was done, there was a study that was done recently here, and for somebody's PhD dissertation, you have some that actually has primers for syphilis, chlamydia, gonorrhea. So you can do all those tests. You can amplify the DNAs of all this at once. So just a pictorial representation of what I was talking about, the denaturing, the annealing, and the synthesizing. Okay, the synthesizing and the annealing. And I talked about microscopy. So in our environment here, we still do microscopy, either the direct visualization of the organisms. So for gonorrhea, you see a gram-negative intracellular diplococci. So when you do a gram stain or a methylene blue stain, you see the intracellular diplococci. So, and I mentioned the samples that you use already. So for syphilis, it's a specialized type of microscopy, and it's highly dependent on who is doing the microscopy. And so that's why that's why tests like nucleic acid amplification, gives they're highly sensitive. So it's called a dark field microscopy. And for trichomoniasis, it's called a wet mount microscopy. It's a direct microscopy to examine for the organism, for the Trichomonas vaginalis. And it's also, you have to do it within 1 hour if you really want to get the organism. And there's this AMCEL criteria for diagnosing Trichomonas. So it has 4 components, and you need about 3 out of the components to make a diagnosis of trichomoniasis. And so it's a thin white yellow homogeneous vaginal discharge, clue cells on microscopy, and clue cells actually refer to vaginal epithelial cells that are surrounded by cocobacilli. pH of vaginal fluid greater than 4.5. So this is non-specific because you can have pH of vaginal fluid greater than 4.5, even in trichomoniasis, because the normal pH of the vagina is supposed to be less than 4.5. It is acidic. Then there's a release of a fishy odor. In fact, when the patients are coming to you, patients that have bacterial vaginosis, they can tell you that when I have sexual intercourse, my partner complains that there's a fishy odor, so they can give that complaint when they present. So a potassium hydroxide test can be done to examine for fungal hyphae. And so when you put 10% potassium hydroxide on a sample that has bacterial vaginosis, that fishy odor also emits. So that's the AMCEL criteria. You need 3 out of that 4 criteria. So those are point of care tests, and those are commonly done. Those are some of the tests that we commonly do here in Nigeria. So culture, this is applicable in gonorrhea, chlamydia, chancroid, HSV, trichomoniasis, candida infections. And traditionally, cell culture was the gold standard for diagnosis for chlamydia using McCoy cell lines. And it is quite cumbersome to do. So non-culture techniques such as direct fluorescence assay, enzyme immunoassay, and this nucleic acid amplification that I mentioned, they've replaced doing culture. For Neisseria gonorrhea, you need a selective and enriched medium that has an increased CO2 environment, like the modified Thea-Martin's agar. So it's necessary for the culture of gonococcus. So that is the agar that you use to culture Neisseria gonorrhea. Tube culture isolation, that's the standard, gold standard for HSV detection, and commonly used cell lines are fibroblasts and viral cells, but nobody really does, all this culture anymore. But there are some specific cases where even if you do a nucleic acid amplification, you need to do a culture. So if you're suspecting that there's in gonorrhea and chlamydia, you're suspecting antimicrobial resistance. If you have a case of abuse, extragenital abuse in females, you may need to do a culture. And some labs also have to retain the ability to do culture because you need to do this antimicrobial susceptibility testing. So rapid diagnostic tests, lateral flow assays tests are available for HSV, HIV, chlamydia. Then ELISA is available for syphilis, HSV, hepatitis B, HIV, and chlamydia. So at this point, I want to talk about the treponemal specific tests and the treponemal, those are tests that are used to diagnose syphilis. The treponemal specific and the treponemal non-specific tests. As the name implies, treponemal specific. They are tests that are used, you use it together with the non-specific treponemal test. So the non-specific treponemal test serves as a screening test when you want to diagnose syphilis. And they are commonly the venereal disease research laboratory testing and the rapid plasma reagent. So when you test and you have a positive test, you then go on to do the treponemal specific test, such as the fluorescent treponemal antibody absorb test, the treponemal pallidum particle agglutination, the treponemal pallidum immobilization test. And so you need these 2 tests. They are complementary to each other. So you use the treponemal non-specific test as a screening test, and you follow it up with the treponemal specific. And it's important to note that treponemal specific test is not useful in monitoring the patients that have syphilis, because usually, most of the time, they remain positive for life. But in some cases, the titers may reduce. But for treponemal non-specific tests, they can be positive in other infections. They can be positive in HIV, can be positive in autoimmune diseases. So that's why it's important to do it together with the treponemal specific tests. And the non-treponemal tests are used in monitoring the patient. So you have a patient you are treating for syphilis and you want to monitor the response to treatment, you use the titer of the non-treponemal specific test. I mentioned the samples that are used for testing already, so I won't go into that again. And again, now moving on to the management. The management of sexually transmitted infection, it depends on the specific sexually transmitted infection you're managing. And like I said, it's not just treatment, it's managing. So there are 5 C's of STI management. So it has to be reinforced when you are managing STI patients. So the counseling of the patient, contact tracing, you have to reinforce the use of condom. And it's important to note that when you're when you're reinforcing condom use, you have to tell them that while you are treating this STI, you are better off abstaining from sex, especially when they are genital ulcerative STIs. So condom use, contact tracing, counseling, compliance with therapy. And the final one is confidentiality, okay? There's something we call the expedited partner therapy. It's actually recommended for chlamydia and gonorrhea, even in some states in the United States. It's also called the patient-delivered partner therapy. So if you envisage that this kind of patient is not going to bring his or her partner, you can deliver the drugs to the patient through to the partner through the patient. There are some diseases that health departments, you have to notify the health department, like gonorrhea, chlamydia, acute HBV infection, acute HCV, HIV, and syphilis. And again, there's something we call rescreening and retesting. So rescreening for most of the for most of the sexually transmitted infections, especially gonorrhea, chlamydia, syphilis, you should rescreen after 3 months. You need to retest if you are using an alternative. So after treatment, most of the time after 14 days, you may need to retest, especially if you use an alternative drug for therapy, apart from the drug of choice when you are treating patients with chlamydia and gonorrhea. So of the sexually transmitted infections, gonococcal resistance to antimicrobials is the most worrisome now, where I report there are pockets of resistance to other sexually transmitted infections. But for gonococcal resistance is the most worrisome. And in fact, there's this gonococcal isolate surveillance project that monitors antimicrobial susceptibility patterns in the United States. And it does a monthly testing of 25 to 30 symptomatic men of 25 symptomatic men in 25 to 30 STD clinics. And so it was discovered that the minimum inhibitory concentration for ceftriaxone and cefixime, which are the extended spectrum cephalosporins that are used to treat gonorrhea, the minimum inhibitory concentration for ceftriaxone is 0.25 microgram per mil for ceftriaxone and cefixime, and is 1 microgram per mil for azithromycin. Anything above 0.125 microgram per mil for ceftriaxone and above 2 microgram per mil for azithromycin, that organism is deemed to be resistant to that antibiotic. So an update to the CDC's treatment guideline. There was a treatment guideline in 2015, but there had to be an update in CDC treatment guideline for gonococcal infection. And it led to an upward review of the treatment of gonococcal infection. Initially, it was at 250 milligram of IM ceftriaxone. Now it's at 500 milligram of IM ceftriaxone. And dual therapy is not actually recommended, especially if you have the facility to test for chlamydia. But if you don't, and you suspect that the patient has chlamydia, you give IM ceftriaxone 500 milligram with doxycycline BD for 7 days. So for persons weighing greater than 150 milligram, a single dose of IM ceftriaxone at 1 gram should be administered. For chlamydia trachomatis, so I've put alternatives. So for gonococcal infection, except if ceftriaxone is not available, that is the treatment of choice. For chlamydia trachomatis, either azithromycin or doxycycline. But azithromycin has the convenience of a one-off dosing, so it might be more convenient. If you are suspecting a patient has both chlamydia and Mycoplasma genitalium infection, it's better to use azithromycin because Mycoplasma genitalium infection is more sensitive to azithromycin. For trichomoniasis, metronidazole 2 grams per oral once is recommended, or tinidazole, none is superior to the other. And for bacterial vaginosis, metronidazole either in oral form for 7 days, or metronidazole gel, or clindamycin cream. For HSV primary infection, there are 3 drugs there that HSV is susceptible to for the primary infection. And we know that HSV can establish latency, and you can have recurrent infection. So if you have patients having recurrent infection, about more than 5 episodes in a year and up to 10 episodes in a year, you might want to do something we call the long-term therapy or episodic therapy. So you might want to do the daily therapy, daily suppressive therapy, which has been shown to be more beneficial than the episodic therapy. But for the primary infection, acyclovir, valacyclovir, and famciclovir are effective. But you might want to do acyclovir or valacyclovir because of the convenience of dosing. But here in Nigeria, we do more of acyclovir because it is cheaper and it is readily available. So there are some existing antimicrobials that are under different phases of trials for gonococcal infection. Like I mentioned, gonococcal resistance is the most worrisome of the sexually transmitted infections now. So these are some of the existing antimicrobials, ertapenem, fosfomycin, gentamicin. So they're under evaluation, and some of them are in different stages of their trials. So some preventive strategies for chlamydia, gonococcal infection, syphilis, and there's listed there doxycycline, and they're all still in the pipeline, okay? So these particular drugs, they have potential, they are novel drugs that are, some of them are already in existence, and some of them they're in different phases of trial, different phases of clinical trials. In fact, in Europe, for pristinamycin is already available by special access in Europe and in Australia. Citalfloxacin is a 4th generation cephalosporin. So some resistance has been noted, either induced or in selectory laboratory strains, have been identified with zoliflodacin, gepotidacin, solithromycin. Some resistance has been noted even during this study, but they are still under different phases of the clinical trials. So I mentioned syphilis, primary, secondary, and tertiary syphilis. For all stages of syphilis, benzathine penicillin is the drug of choice. What differs is the dosing, the dosage that you're going to use for the different stages. So for primary, secondary, and tertiary syphilis, for primary syphilis, usually in a single dose treatment, and benzathine penicillin G. One of the problems with syphilis management is some people use other types of benzathine penicillin, other types of penicillin that is not benzathine penicillin G, and that increases the risk of resistance. So an alternative is doxycycline, but that alternative is not advocated at all. So the best form of treatment for syphilis is benzathine penicillin. If you have a patient with penicillin allergy, you can desensitize the patient and still use benzathine penicillin. And for most of these infections, except it is complicated, for whether they are HIV positive patients, whether they are men who have sex with men, the treatment is the same, except when you have complicated cases. So early latent syphilis, the treatment is as stated there. Late latent syphilis, neurosyphilis, you have to give 3.4 million units IV every 4 hours or a continuous infusion. So like I mentioned before, chancroid, lymphogranuloma venereum, granuloma inguinale, they are not so commonly seen. Even here in Nigeria, we've not recorded any case in the last 1 year in our clinic. The last 1 year, even in Lagos, I looked at the records in Lagos too. So this is the treatment for LGV, for chancroid, and for granuloma inguinale. For genital warts, the treatment can include cryotherapy with liquid nitrogen, electrosurgery, use of 80 to 90% trichloroacetic acid. You can even do surgery for large ones. But the treatment is dependent upon patient and physician factors. There's no single treatment that is superior to the other when it comes to genital warts treatment. Pelvic inflammatory disease, the treatment is parenteral, with parenteral cephalosporins with doxycycline or clindamycin, either parenteral or oral, depending on the severity of presentation. And genital warts, particularly important to us here, we see a lot of it in the clinic. So this is one of our patients that had genital warts. We treated with cryotherapy and he did quite well. So some therapies that have been developed for controlling STIs. So vaginally administered agents containing small interfering RNAs, targeting host factors like chemokine receptor, viral genes, so that the NEF gene, the integrase. In HIV, there are potential agents that can be used to control STIs. But for now, they're still potential agents. And some of them also target some sequence of high-risk HPVs. They are E6 and E7 genes. So I need to mention syndromic approach to STIs at this time, because for a lot of developing countries, low-income countries, that is what is still practiced. So where access to timely diagnosis and supporting laboratory facilities is limited. And it involves the use of a constellation of symptoms and signs that are associated with specific STIs to make a presumptive diagnosis. So it's classified into different syndromes, either associated with urethral discharge, or associated with vaginal discharge, genital ulcer disease, or lower abdominal pain to signify pelvic inflammatory disease. The algorithm is more sensitive with urethritis than vaginal discharge. The major advantage is that it encourages prompt treatment, thereby reducing the risk of complications. The major disadvantage is that it's asymptomatic, because if they are not symptomatic, you cannot use that algorithm to manage them. So asymptomatic people will go untreated and they form a reservoir for infection. So for men, STIs, the risk of not treating them in good time is the risk of transmission. Although complications can resolve, but majority of men would have symptoms. For women, majority of them would not have symptoms. So the effect of that, not treating them promptly, is the risk of complications, like I mentioned before. So there are some CDC recommendations for screening different groups of people. Like I mentioned, women less than 25 years, greater than 25 years. So for women less than 25 years, an annual screening of genital gonococcal and chlamydial infection, HIV screening at least once. You should screen for syphilis, trichomoniasis, HBV, and HCV if they are at high risk. If they are HIV infected, you screen for genital chlamydia, gonorrhea, trichomonas, and syphilis annually. For HIV uninfected men who have sex with women, you should do an HIV screening at least once. Then for HIV uninfected men who have sex with men, you need to screen for genital chlamydia, gonorrhea, syphilis, rectal and pharyngeal gonococcal infection, and chlamydia infection. You need to screen for all that. Okay, you need to screen for all that. Then HIV infected men who have sex with women, genital chlamydia, gonorrhea, syphilis annually, with HBV and HCV at least once. And like I mentioned before, most frequent screening for gonococcal infection, chlamydia, and syphilis might be recommended in those people with some of those risk factors that I've listed before. For HIV infected men who have sex with men, you need to screen for genital chlamydia, gonorrhea, and syphilis, with rectal gonorrhea and syphilis if they are exposed, depending on the kind of sexual orientation that they have or the kind of sexual practice that they do. So hepatitis A virus, hepatitis B virus has to be screened for at first visits, and HCV at least once. So what is the way forward with sexually transmitted infections? So there's this, there in the United States, there are a lot of school-based community screening to help improve diagnosis of asymptomatic cases. I'm bringing it down to my own region. If we don't have, our healthcare is not so fantastic yet. So primary prevention, primordial prevention in a way that is relatable with the general public. Even if you are going to adapt the kind of counseling that is being used in industrialized countries, we have to individualize it for this environment. You may need to use different languages to give that education, sex education. Then self-testing. For trichomoniasis, a study showed that self-testing with samples that are taken by the patient themselves has almost the equal sensitivity as the one that is taken by the clinician. So patients, even testing for those samples is not so comfortable, exposing the patient. So self-testing might be a way for more testing of asymptomatic people. Continuous education about safe sex. And safe sex is not just about using condom alone. It's even about the kind of partners that you have sex with, the kind of sexual practices that you do. You must ensure that you practice safe sex. Eliminating stigmatization against men who have sex with men. That is particularly important here. Retraining of healthcare workers. I have seen some healthcare workers, look at people with sexually transmitted infections, in a way that is unpalatable. Dispelling myths around sexually transmitted infection. And some of those myths, particularly important in Nigeria, in our environment here. There's this saying, we say it in broken English, AIDS no dey show for face, So it's important to reemphasize this, saying that sexually transmitted infection, the fact that you are dressed nicely, the fact that you look good, does not mean that you cannot have a sexually transmitted infection. You cannot have a sexually transmitted infection. And another thing is that some people believe that if you are not symptomatic, you don't have a sexually transmitted infection. Then establishing solid surveillance system in form of screening, improving access to etiologic diagnosis, especially in areas where etiologic diagnosis is deficient, research and public health initiatives, especially to develop new antimicrobials. We shouldn't wait until we now have complete resistance to extended spectrum cephalosporins before we have new antimicrobials that will take care of gonococcal infection. Antimicrobials and therapeutic regimens should be tailored towards, the ones that have once daily dosing or one-off dosing for ease of compliance. So this is the CDC strategy to reduce sexually transmitted infection. Risk assessment, education, and counseling of persons at risk on ways to avoid sexually transmitted diseases through changes in sexual behaviors, and use of recommended prevention services. So again, pre-exposure vaccination of persons at risk. So if you know that you are people that are at risk of vaccine preventable STDs. So HPV vaccination is not in our own national immunization schedule, but we hope it will be there soon. You can start HPV vaccination as early as 9 years. So, and annual screening is not recommended for screening for cervical cancer anymore. It's you screen starting from the age of 21 years, and you do that every 3 years until the person gets to 30. Afterwards, you can do it every 5 years. So screening for cervical cancer is highly important. Identification of asymptomatically and symptomatically infected persons, effective diagnosis, treatment, counseling, and follow-up of infected persons, and contact tracing to trace those people that are sexual partners of those infected. The World Health Organization has a global strategy, okay, has a global strategy for a 90% reduction in T. pallidum incidence globally from the 2018 global baseline, the 90% reduction in Neisseria gonorrhea incidence globally, 50 or fewer cases of congenital syphilis per 100,000 live births, sustain 90% national coverage, and at least 80% in every district in countries with the human papilloma virus in their national immunization program. And so this is the World Health Organization global strategy on ending sexually transmitted infection epidemics as public health concerns in line with the by 2030, in line with the Sustainable Development Goals. So in conclusion, what are the take-home points from my presentation? Majority of STIs, especially in women, are asymptomatic. The burden of STIs is mostly felt in women, adolescents, and young adults. Extragenital infection is an important mode of transmission, especially in men who have sex with men. And they are a heterogeneous group with increased risk for certain sexually transmitted infections. Resistance to most antibiotics used in treating gonococcal infections. And so nucleic acid amplification tests are the gold standard now presently for diagnosing gonorrhea and chlamydia and even trichomonas infections. STIs are still a major public health issue. We shouldn't rest on our oars yet, and every stakeholder involved in STI must act together now to make STI become something of the past. So I like to speak, to speak in adages. A Yoruba adage says, Tino baton lasho, eje otole ikono. That means we still have a lot of work on our hands. There's still a lot of work to do. So these are my references. And just on a lighter note, when I said bring something to the party, I wasn't expecting you to bring an STD, So this meme says your STD panel came back. It turns out that what happens in Vegas does not stay in Vegas. So what happens in Vegas in form of you have, had a nice time, picked up a random partner, you might have complications of that even much later. And remember, chlamydia is not a flower. Don't let them offer chlamydia to you. So special thanks to Professor Rashid Bakari, Dr. Boyega Olareye, Dr. Abike Fowotade, and Dr. Chinwe Onyekon for their help with some of the slides in this presentation. Thank you very much.
Thank you so much, Dr. Gold. And thank you to our audience for bearing with us with some of those technical difficulties. So we have some questions. Bill, did you want to do that one that you were fielding?
Sure. It looks like we have someone's raised their hand. Adebola, I'm going to try to allow you to talk. Let's see if it'll unmute you and allow you to ask your question. Alternatively, you're welcome to put it in through the chat. But here we go. Are you able to hear us or talk? It looks like you might be muted on your end. Okay, looks like that might not be working. Maybe we can have that question come into the chat if possible.
Okay, the next question we see is someone who's interested in neurosyphilis diagnosis and management. He or she says, that was a wonderful talk, Dr. Gold. Their question is, how much do you see and diagnose given people are hesitant to access care for cultural reasons and possibly a lack of awareness of symptoms? Are people amenable to lumbar puncture, or is it mostly a clinical plus serological diagnosis for neurosyphilis? Okay.
So yes, they're open to, they agree to have a lumbar puncture. But I have to state that syphilis is so uncommon now. I've been doing dermatology or dermatovenerology for almost 7 years now. And I've not seen a single, I've seen like 2 cases of syphilis, primary syphilis. For neurosyphilis, when I was doing my neurology posting, I saw one and they had a lumbar puncture done. And if you have neurosyphilis, the patient was on admission. So it was easy to, do the lumbar puncture. We had the serological diagnosis, the clinical diagnosis, and the patient had IM benzathine penicillin while on admission. So that's what the patient had. So I hope I've answered that question.
Yeah, I think that was good. We have another question from Kakya Bregovadze. I'm apologizing if I'm saying your name incorrectly. They ask, is doxycycline really effective in syphilis? Is there any study comparing the effectiveness to benzathine benzylpenicillin?
So most of the studies actually, and that's why I reiterated that when you're managing syphilis, the drug of choice is still benzathine penicillin. The doxycycline was put there just because in some cases, and benzathine penicillin in most areas is quite cheap and easy to get. So, but there are some patients that you cannot even desensitize them if they have penicillin allergy. So you may need to use doxycycline. But most of the studies done, benzathine penicillin is still the drug of choice. Okay, so I hope I've answered that question too.
Yes, and we just have Monty is saying that, wow, I think this was in regards to the neurosyphilis. Wow, that's fascinating. Okay. In London, we see loads of cases. Thank you. Wow. And Olusola Ayanlowo is saying, nice presentation, Dr. Gold. So you have a lot of people who really enjoyed your presentation and learned a lot from it.
Thank you.
Yeah.
Despite the technical itches. Thank you.
So I actually have a question. Do you ever find that it's helpful to provide other supportive care in addition to the antimicrobial agents? Like anything, so how do you barrier function or anything like that?
So barrier function, like to give them
of the epithelium, like I don't know if anybody, like does a moisturizer help or like anything like that to help with like epithelium like barrier function?
So I think it might help with we really don't put that as part of the management, but it might help perhaps to improve the integrity of the skin and all that. But to prevent the infection itself, it doesn't do just the moisturizer, the barrier creams and all that. It's not really going to do much. And for Nigerian patients, we have to be careful when you are giving them things like that. When you do something like that, they will just tell you that, oh, this cream that the doctor has given me it's going to prevent all forms of sexually transmitted infections. So you have to be very clear when you are dealing with our patients. So we make sure that it's the treatment that we really concentrate on when we are talking about when we are treating the patients with STIs. And if you remember, I mentioned some drugs that are in the pipeline, like the doxycycline, some topical drugs that are in the pipeline, the topical small interfering RNAs. They have not been shown to prevent these sexually transmitted infections, because by the time you say they prevent these infections, there's a tendency for people to have this laxity towards protecting themselves when it comes to sexually transmitted infections, and they don't use the proper protective mechanisms anymore. So I think for now it's still safe to say that these drugs, you might use them as adjunctive therapy, but not exactly to prevent the infection per se. Then Monty, you said something about you see loads of neurosyphilis in London. I think the reason why we are not seeing syphilis that much in Nigeria again is because, like I mentioned earlier, a lot of people in Nigeria, when they have any infection or when they have anything, the typical thing is to go to the local chemist. It's not like, prescriptions are not as easy to get over there. They go to the local chemist and they buy anything they want. They just go there, get some, except for some really, for some drugs that cannot be gotten without a prescription. Okay, like for example, if I prescribe isotretinoin, you're not going to have any pharmacy dispense that without a prescription. But in fact, some chemists, let me put them that way, in Lagos, they are actually giving injections in their chemists. So the reason why we probably don't have syphilis that much is because a lot of people have taken benzocaine penicillin at one time or the other. So that might be responsible for one of the reasons why we don't have syphilis that much.
Yes, makes sense. That's interesting. I don't think pharmacists here can do an injection bolus of an antimicrobial.
Definitely not. Yeah. Definitely not. Yeah. That's one of the things that we have to address here.
And thank you for pointing out. You're exactly right. I don't want to give people the wrong impression that you could just use a cream and be protected. That's exactly. We have a couple more people in the chat who are commenting about public health interventions with condoms, saying that they know they're not foolproof, and trying to train people in their use and proper use is also an issue. And I think these are people from both Nigeria and Pakistan that said they had problems with that. They say it's tricky to navigate this space. So I don't know if you have any tips. I know you mentioned education as being one of your primary ways to move forward.
So I like the fact that this was mentioned, because using a condom, I've had a patient that when you want to use a condom, it has to be used, especially for the male condom, you have to use it on an erect penis. But this patient actually did not know that. So some people are using condoms, they don't even know how to use it. And like I mentioned before, you have to tailor your health education, towards, the environment that you are dealing with. If I want to do a health education program in Nigeria, for example, I would want to translate it into the major, the languages spoken in Nigeria. Apart from English, is a lot of people speak, that's our lingua franca here, but we have a lot of other languages. I am Yoruba, for example. We have Igbos, we have Hausa, we have Kanuri, we have so many languages, but almost everyone can speak Pidgin English. If you remember while I was presenting, I said something about AIDS, no, they show for face. So that's broken English. So if I was going to do a health education in Nigeria, for example, I would have it in, the 3 major languages spoken in Nigeria. And even in some other areas, I would be going into the grassroots. I would not put it on just the internet alone. I would have it on the radio. Almost everybody, especially those in the grassroots, they listen to jingles, radio. They listen to it a lot. They will have a transistor radio in their house. Not everyone has access to the internet. And I'll do some in Pidgin English. Everybody, almost a lot of people, even the market woman in Nigeria, they speak Pidgin English. So you have to tailor the health education to the environment that you are doing that health education in. So I hope that has been.
Yeah, I love that. That's great.
Yeah.
I think that's such a great idea too, to make it more accessible, like just doing radio
Yes.
or in-person education. I love that. Yeah.
Yes. Yes.
Yeah.
All right. Thank
Cool.
you.
Well, we're a little over time, so thank you for your talk, Dr. Gold. And
Thank you
so
so
many
much.
people from the audience are saying thank you for a wonderful presentation. So
Thank you.
and I guess we'll be back next month with more talks. So thanks, everybody. Take care.
Thank you. Thank you, Jillian. Thank you. Bye, everybody.
Bye.